why is the percentage of cough more in Iraq and Iran?
So, one second, where is it? Okay, it's not in the chat, huh? I think in
It
Iraq
is,
and
sir.
Iran, I don't know. I think I can't tell you what is the reason. I think if it is dust pollution, I think that I think the experts from Iraq and Iran have to comment on that. But from what I understand is that pollution like it is here could also be a reason.
Another, sir, since cough becomes an overlapping condition, like because of many etiologies, the cough can be there. So, how do we differentiate such cough as acute, subacute? Because, gauging which exact cause of the cough is there. So, how at that point of time, how will you?
So we have to go in a very systematic manner. Sometimes say you have an individual who has come with a very classical history of rhinitis, rhinosinusitis. It looks as an upper airway cough syndrome, and you treat that. Now, suppose if and you treat that, this individual gets just a partial benefit. We say, oh, this individual actually have made a diagnosis. We know that there is, we have the diagnosis, we have the treatment. Why there is a not a symptomatic, adequate symptomatic relief. So these guys will give you partial. That's when you need to look for other causes. This individual may have a gastroesophageal reflux, so you need to look at reflux also, for example. So you need to go sequentially. At the first go, if two diagnoses are apparent, you treat both of them. If at the first go you say, okay, one is a dominant and a strong diagnosis, you would treat them, reassess, see what the benefit is of the medication based on the clinical diagnosis, and then you can add on the code sequentially. So it's a step by step. And then, of course, you do various tests to help you to guide, what direction to take.
Questions which talk about if you could highlight some breathing exercise and throat massages that was written on the slide.
So if you go from the breathing exercises, there are different breathing exercises. For one breathing exercises, I think in India, what really helps a lot of people and is accepted is the yoga. So yoga and the pranayama exercises, just the systematic and regular breathing actually helps a lot of people. I don't have very strong evidence to support that, but we have patients. Who have a lot of benefit based on that. So that is in experience and in practice a benefit. The exercises that you would do is again you would do a systematic breathing. If there is a phlegm that has to be coughed out, you would take in a deep breath. You would hold the breath and then you make a fast repulse. You make a fast expulsion and you make them and then you make them cough. The other breathing exercise, particularly exercises, become important. So the important thing is that you ask them to breathe in a rhythmical manner. The other most important thing in the exercises are the postural drainages, particularly for individuals who have bronchiectasis, and the postural drainage exercises, along with the breathing exercise, help to remove the cough, which is stuck in the airways. So as I showed you in one of the X-rays, there, clearly you could see a air fluid level, and that air fluid level clearly meant that in that individual with bronchiectasis, the phlegm is stuck there, and the only way you could that exercise would help in bronchiectasis would be a postural drainage. So these postural drainage exercises need to be performed on a regular basis. We say that it should be done at least daily in all these patients, and even if they are not bringing out any secretions, you still continue to do it. That means you don't allow the secretions to accumulate.
Another question we had is, how is the approach to cough treatment different in pediatric patients when we compare it with adults? Like we saw today about adults, how is it different in pediatric patients? If you could, just give a small brief about it.
So typically also, but I do see some pediatric patients with asthma and chronic cough time to time. And I must tell you, the most common diagnosis that come across in these pediatric patients is post-nasal drip, that is the upper airway cough syndrome, that is allergic rhinitis. And another thing is bronchial hyperreactivity. And often what happens at the pediatric level is that bronchial hyperreactivity is only treated with a few, the nebulizers on an on and off basis or inhalers on an on and off basis. And these are the individuals who may need the inhalers for a longer time, and the treatment also for the rhinosinusitis also. So I think that is the cause. The other common reason of cough I see in pediatric practice is also in some children who have a gastroesophageal reflux, and sometimes just good counseling in terms of the timing of the meals, and sometimes giving them some prokinetic agents for a small duration helps. And then subsequently, these individuals will need to be I typically don't treat pediatrics for a long time, but these are the reasons for pediatric cough that I come across on from a time to time basis.
There's one more interesting question, sir. Do you know about a 100-day cough and how best to treat it? If you can tell us about it, it is a long-lasting cough that is not responsive to treatment but goes away after a couple of months.
So I think when we talk about 100-day cough is like a chronic cough, So what we are talking about is 8 weeks of cough. So 8 weeks. So if you take subacute cough is up to 8 weeks. So if somebody has a cough for more than 3 weeks, it becomes the 100-day cough. So you have to go into the category of subacute cough. So for the patients who have a subacute cough, you need to look at the X-ray chest, a CT scan if required. You need to do a pulmonary function test. You need to look for reflux, and you need to maybe do a flexible laryngoscopy to look at the vocal cords, etc. So I think we need to, like I discussed, we need to follow the steps which are required, which we discussed in the evaluation. So anybody who has a cough for 3 weeks will definitely, you need to move on from symptomatic treatment to a investigative mode and a much more detailed clinical assessment.
There are a couple of questions more, and then I think we can end. There is a question which talks about how long should we give polyhormonal cough syrup like Z-Cough, and is it suitable for pregnancy?
So I don't know about pregnancy. I think you need to look up for that, for the pregnancy thing. But I think you need to know because the recommendations of pregnancy keep on changing. So for all pregnant women who come to us, we are regularly checking each and every medication on things like up to date or whatever resources available before we send them or prescribe them therapies. Now, I think we need to follow the guidelines. All these cough suppressants are used for acute cough. So acute cough is something where the lozenges, Z-Sub, etc., would have a role. So the dominant role will be in patients with acute cough. In patients with subacute or chronic cough, I think you're looking at other things. But if these individuals are working, and at work, if it is affecting, they're having a meeting, they're having some silent area, and they want to temporarily, just temporarily get relief from the cough. In that case, of course, it can also be used, but it is not something that is recommended to be taken on a long-term basis. Anybody who needs a cough suppressant for a longer time, you must evaluate for the reason of the cough, make a detailed clinical evaluation, and investigate appropriately.